Speakers beware. Thank you all for coming to this course. I think it's going to be an exciting course, and the idea behind it was really to try and help people sort of jump the learning curve by having people up here that have done, for the sleeves, certainly well over 500, and for the bands, we upped that to about 1,000, just so that we could give you the best experience. And all the speakers that are coming are well known to most of you, if not all of you, and they are really leaders in the field, and it's really been my honor that they agreed to come to this course and join in. So to start off, we're going to have Dr. Sayeed Ikramuddin come up, and Sayeed, again, well known to everyone, but he has a specific interest in diabetes management, and he really can clarify a lot of the interesting hormonal aspects of the sleeve procedure for everyone. Thank you.
Thank you, Dr. Korean and Dr. Rivas. It's really an honor to be able to talk to you about, I think, a very challenging area. The classic teaching is that the sleeve initially is a biologically inert operation, a restrictive operation, and lacks greatly the robustness, the endocrine robustness of the of some of the malabsorptive or mixed operations like the gastric bypass. And what I want to try and do is really focus on the data that we have for sleeve gastrectomy and see if we can get a better idea of how it may interact with some of the mechanisms that regulate appetite and satiety. So just by way of introduction, what is the evidence that we have in comparison of the sleeve to other bariatric operations? And it appears to be remarkably robust. In these studies you can see 4 of them are level A or grade A evidence, which basically means randomized controlled trials. And in each of these randomized controlled trials, the weight loss, the percent excess weight loss of the sleeve gastrectomy was either similar to, and in some cases better than, the Roux-en-Y gastric bypass. And in comparison to the band, superior weight loss. Interestingly, though, and you can see this, interestingly, though, the body mass index being the same in some of the randomized trials, that the improvement in hemoglobin A1C was better in some of the Roux-en-Y studies, but in some of the other studies, like Vidal, for example, resolution was equivalent in both the sleeve and the Roux-en-Y gastric bypass. So some mixed data despite very similar weight loss results at 1 year. So this is, as you eat breakfast, something to ponder. The whole pathway for obesity and satiety is very complex. I want to take about 2 or 3 minutes just to go over some of this so you understand. This is modified from a paper from Schwartz from 2005. The key component of obesity, the central factor, is the ventromedial hypothalamus, the paraventricular nucleus, and specifically the arcuate nucleus. The arcuate nucleus is a receptor site for multiple different inputs, from the small intestine and large intestine, which is GLP and PYY, Ghrelin from the stomach and epsilon cells of the pancreas, the fat, which is remarkably biologically active, insulin from the pancreas, free fatty acids, which are liberated. All of these cells, all of these moieties will interact either on the neuropeptide Y or agouti-related peptide neurons within the arcuate nucleus. Now, this is very important. If you remember anything from this talk, this is the key thing to remember. Neuropeptide Y neurons are bad in terms of promoting adiposity, slowing metabolism, and they make people eat more. They reduce energy expenditure, and they work by basically stimulating the Y1 receptors, which will then go through orexigenic or eating pathways. And then the agouti-related peptide, which also sits in these neuropeptide Y neurons, will suppress these pro-opionomelanocortin receptors or pathways, which are ones that are considered to be catabolic. So some of these peptides will react the neuropeptide Y, some will react at POMC, but at the end of the day, neuropeptide Y is the mechanism which increases appetite, reduces satiety, reduces energy expenditure, worsens insulin resistance, worsens adiposity through this mechanism. So if you think about it simply, in patients who have obesity or eat a meal, for example, if a thin person eats a meal, free fatty acids will be liberated from fat. They will then embed themselves in the neuropeptide neurons and basically create a sensation of satiety after esterification. In obese people, there is resistance of these peptides. That's the key thing to remember. Resistance of all of these peptides at the level of the arcuate nucleus causes the disease that we see in obesity. Let's focus on fat for a little bit. Adipose tissue, once thought to be completely biologically inert, now is a remarkably active area. The increase in fat, particularly in the subcutaneous tissue, and then ultimately visceral tissue, causes a significant amount of inflammation. And the inflammation in turn, with the increase in adiposity, can lead to liberation of a number of inflammatory signals. So envision that as fat cells increase in an area, you may have necrosis. Necrosis may lead to inflammation, and inflammation will lead to cytokine production within the fat cell itself. Now, there's a vast debate between subcutaneous tissue and visceral tissue. And many people herald visceral, that is in the abdomen, the abdominal fat as sort of the key marker. And I would argue that that is not entirely clear. Basically, inflammation and some of the cytokine liberation really represents a disease of the fat. The inability of the fat to appropriately store and handle nutrients. And when this capacity is overwhelmed by too much nutrition, fat will be deposited in places it shouldn't, such as the muscle, for example. It just spills out into the muscle, which worsens insulin resistance. Locally, it causes inflammation also with release of the cytokines. The key cytokines that we talk about, and there are several, are leptin and adiponectin. Okay, I want to talk about leptin independently because it's one that we really have heralded as a key peptide in regulation of appetite and satiety. Now, I apologize for how small this is, but in a lean person, if you increase your leptin levels, okay, so as opposed to having no leptin, if you increase your leptin levels, you will drop, it decreases neuropeptide Y secretion. Okay, at the level of the ventromedial hypothalamus. That means less food intake, lower body weight, increased sympathetic tone, okay, increased energy expenditure, decreased glucose output from the liver. And that's what affects basal insulin resistance. It's when you sleep, your liver puts out glucose. The more glucose that your body puts out, the higher your fasting plasma glucose, and that'll affect your insulin resistance. And so that's all well and good for people that are lean when you give them leptin. The problem is in obesity, and all our patients, is this tremendous paradox we see with virtually all of the adipocyte-derived peptides, which is that these are now elevated in severe obesity. So I just got done telling you that if you put leptin into a thin person, it reduces their appetite and reduces their energy expenditure. Now I'm going to tell you that in obese people, leptin is higher. So there's a paradox there. I'm telling you two opposite things. And what you need to understand is that leptin may also be a marker of long-term weight balance, but they're also, like insulin, can be leptin resistance in the brain itself. We all are familiar with the concept of insulin resistance. This is the concept of leptin resistance. And it's this resistance to leptin, either by leptin receptor abnormalities in the brain that force higher levels, that then cause problems with neuropeptide Y, inability to suppress neuropeptide Y secretion. So that's an interesting concept. And so a group from Cincinnati really wanted to study this. So it's accepted that if someone goes on a diet and loses weight, their leptin levels go down. If someone has any kind of bariatric surgery and loses fat mass, their leptin levels go down. The question is, does the sleeve gastrectomy, or any other operation for that matter, improve leptin resistance at the level of the brain? Because that's the essential question. And so if you look at this rat study from Cincinnati where they performed sleeve gastrectomies, the sham animals and the sleeve, you can see in the yellowish orangish line there that the rats that had a sleeve gastrectomy, they lost weight. They gained weight at the same rate as the other animals, but maintained their weight loss in comparison to the control groups. Okay? So they were able to keep their weight down. They ate more frequently, but they would still maintained a difference in weight. So what this study looked at then is introducing into pair-fed animals that got the same feeding as the animals that had the sleeve, and sleeve animals, they gave them leptin again to see if their response or their energy intake would increase in a different way. And what they found in their animals is that after leptin administration, that it was a difference significantly, but no difference from pair-fed animals. Their resistance to leptin, their leptin sensitivity changed only in parallel to animals that were on a diet, so no significant change in leptin resistance. So still, for all practical purposes, just a marker of whole body mass, and not much more than that. Now, how do we measure insulin resistance, and does the sleeve improve that? There are several ways to do that. The basic bare bones way to do that is HOMA-IR. You can measure it from oral glucose insulin sensitivity by having separate indices. You can look at the intravenous glucose tolerance test, and the gold standard study is an insulin clamp. And there really haven't been any insulin clamp studies done with the sleeve gastrectomy. So you're really left with HOMA-IR. Now, you all have seen HOMA data in papers, so it's important to understand what HOMA means. HOMA is a surrogate marker of insulin resistance, and if you look at the bottom line, basically it's a product of fasting plasma glucose and fasting plasma insulin divided by a factor that's designed to normalize the value to 1. So normal insulin resistance would be 1. And so you'd have 0.5, 0.6 if you were less than 1 or more insulin resistance. But it's static. It only represents basal insulin. And as I told you before, if you have increased glucose output by the liver, that is to say, if your liver is insulin resistant, because that's the only thing that regulates glucose while you're fasting, really HOMA only represents hepatic insulin resistance and not whole body insulin resistance. So you can't say whole body insulin resistance is changing, only specific to the liver. And what we see in patients who were medically managed in the white compared to patients that underwent a sleeve gastrectomy after 2 months, their body mass index changed significantly in both groups on a liquid diet, and their HOMA changed significantly in both groups, but not different between the two groups. In other words, it dropped from 3.27 down to 1.33 in the sleeve gastrectomy group, but an equivalent, essentially non-statistically different change between the two. So HOMA doesn't change in comparison to a vigorous diet. Is it any different from a Roux-en-Y gastric bypass? And this is a Swiss study that looks at HOMA levels in patients at 1 week post-op and 3 months post-op. It's a very clever study, randomized study. And there were just maybe 2 diabetics in each of these groups, 13 patients in the Roux, 14 patients in the sleeve group. And what we see is an equal but systematically significant decrease in HOMA at 1 week and 3 months. Okay? So at least hepatic insulin resistance has changed significantly early on as reflected by HOMA in patients, but not any different, and the Roux-en-Y is not any more superior to the sleeve gastrectomy, and nor is there any difference with diet. So the gut plays a role also in this. We've talked about the fat, and principally we have cells in the terminal intestine which produce PYY and GLP-1, and cells in the stomach that produce ghrelin, and I want to focus on those 3 peptides for the remainder of my talk. Glucagon, enteroglucagon, or GLP-1, is sort of the magic peptide. Of all the peptides today, I think it's the one that holds the most therapeutic promise. GLP-1 comes from the L cells, from the terminal L cells, and it's clear from the proglucagon moiety. It's secreted in the terminal ileum after a mixed meal. And so we really don't care about basal or fasting GLP-1 levels. We care about the levels after a mixed meal. It inhibits pancreatic glucagon secretion. So glucagon, as you know, increases glucose. It's a counter-regulatory hormone. And so by acting like glucagon but having only 20% of its efficacy, it drops glucose release. It decreases insulin resistance, prolongs gastric emptying, decreases intestinal motility, and has high effectiveness in treatment of type 2 diabetes. Why can't you just give GLP-1 to someone? The reason, if you give endogenous GLP-1 to someone, it's broken down within a matter of minutes. There are natural peptides, DPP4, dipeptidyl peptidases, that break down GLP-1 within a matter of minutes. And so the animal, the Gila monster saliva that's used in the pharmaceutical medications that simulate GLP-1 are indeed resistant to breakdown by DPP4. So what does GLP-1 do? It's responsible for something called the incretin effect. And this is something that is another important takeaway message. It's another important takeaway message for the audience. Basically, the concept is simple, that orally ingested glucose will have a more robust secretion of insulin in comparison to intravenously administered glucose. So if you give someone intrajejunal glucose, the rise in insulin will be greater than if you give someone intravenous glucose. And that response, that incretin effect, is blunted in patients with type 2 diabetes. Not all patients with type 2 diabetes, many patients with type 2 diabetes. And that's the incretin effect, principally mediated by GLP-1. And so if we look at patients after gastric bypass operation, where you bypass the foregut, and compare it to operations that traditionally don't, such as the band, and patients that are overweight in weight-matched controls, you can see that the GLP-1 following a mixed meal will peak very quickly early on after surgery in comparison to control groups. So that's the gastric bypass. What does the sleeve gastrectomy do when there's no intestinal bypass, when food is not delivered principally as quickly to the hindgut where these L cells reside? Well, in cross-sectional analysis, if you look at the sleeve gastrectomy, actually we see a relatively robust increase in GLP-1 in comparison to the Roux-en-Y gastric bypass, and far more than the adjustable band. And there are two studies that look at this. One is the randomized study from Peter Lee that I referred to earlier, which is at the top, and there's another one that compares it to medical management at the bottom. And excuse the numbers, but ultimately what this shows is that patients following a mixed meal, okay, and in this case it's a 1,000-calorie meal, that after 1 week you can see a significant increase that persists, actually a significant increase compared to pre-op at 3 months. If you look at the sleeve gastrectomy, also there's a significant increase in the GLP response at 3 months. Now, you wouldn't have normally expected that without an intestinal bypass, and it may suggest an impact on gastric emptying with delivery of food more distally. There is no significant difference, p.084, between the two groups at 3 months. If we compare GLP-1 secretion to patients that lost weight, you can see that the incremental area under the curve, okay, so they're looking at increase at GLP-1, pre-op compared to post-op, no difference in the medical group, and markedly elevated and different from the medical control group in patients after sleeve gastrectomy at 2 months in a group compared to medical management. So indeed, GLP-1 following a mixed meal does go up after the sleeve gastrectomy, similar to the Roux-en-Y gastric bypass, and certainly greater than people that have medical management. Another key peptide is peptide YY. Now, as opposed to mechanisms of insulin secretion, this is one that works in the brain. It's secreted by the L cells in two forms. PYY336, which has selective, works as a selective receptor for the Y2 receptor in the hypothalamus. This Y2 receptor activation inhibits neuropeptide Y. Neuropeptide Y is bad. It makes you fat. It makes you eat more. It reduces your energy expenditure. So this is inhibitory. Okay? And so obese subjects have lower fasting and postprandial circulating PYY than lean subjects, yet they retain full sensitivity to the anorectic actions of injected PYY. And so what are the data that we have? If you look at this, you can see that PYY levels following the Roux-en-Y gastric bypass are significantly increased at about 3 months out from surgery. And in comparison to the the sleeve gastrectomy, no difference at 3 months. Both groups have an increase in comparison to preoperatively. So PYY goes up after the sleeve and after the Roux-en-Y gastric bypass significantly by 3 months, and even as quickly as 1 month out from surgery, 1 week out from surgery, as you can see. And in comparison to patients who, in part of another randomized study comparing laparoscopic Roux-en-Y to sleeve gastrectomy, that you can see in the bottom slide that the PYY levels go up after the Roux-en-Y gastric bypass, and they also go up significantly after the sleeve gastrectomy, with no difference between the two groups. So PYY goes up after both. It's very interesting. Ghrelin, which is the last peptide that I want to talk about, is sort of the key, sort of the golden key to bariatric surgery, at least initially. Ghrelin is the hunger hormone. If you inject it into people, it makes people hungry. At least that's what we initially understood. It promotes adiposity. But the key thing about Ghrelin that you should know is it works through one mechanism that we had originally understood, which is through the GHS receptor in the hypothalamus. It only works at the GHS receptor because of this right here. This is a fatty acid that's bound to this peptide. This is the only peptide in humans that binds a fatty acid in this way. And for this reason, it's suspected that this may have something to do with food intake that metabolizes this. So this is known as the octanolated form of Ghrelin. Why is this important? If you're going to look at active Ghrelin, that's what you have to measure. And not all studies that report Ghrelin output measure this. And so you have to sort of buyer beware as you look at some of these studies. But these studies seem to do that. This is one comparing band and bypass, showing increase in Ghrelin, means you're hungry in banding patients compared to patients that had a sleeve gastrectomy, where it was significantly reduced at 1 day after surgery, and no real change by 6 months, but significant increase with banding at 6 months after surgery. This compares fasting Ghrelin levels in patients in sleeve versus Roux-en-Y gastric bypass, and you can see that in patients with the sleeve gastrectomy, in comparison to Roux-en-Y gastric bypass in a randomized trial, that at 12 months at the sleeve gastrectomy is greater suppression of fasting Ghrelin in comparison to the Roux-en-Y gastric bypass. That's somewhat compelling. And that these results last up until about 5 years out from surgery. You can see from this 5-year follow-up that the Ghrelin levels in the fasting setting will be reduced and stay reduced out till 5 years from surgery. And what about the effect of a mixed meal? A mixed meal is supposed to separate this, comparing to reduce Ghrelin levels. The Roux-en-Y gastric bypass in comparison to the sleeve gastrectomy, that there is a significant reduction in patients who undergo both the sleeve gastrectomy and the Roux-en-Y gastric bypass at 1 week and 3 months following a mixed meal. So both are reduced. And yet that the sleeve gastrectomy is actually reduced more significantly than patients who have had a Roux-en-Y gastric bypass. As you can see at the 3-month interval, more suppression of Ghrelin after a mixed meal, even though both are lower than preoperative levels. So even more of a profound input. There's a lot that can relate to this. We talk a great deal about the bougie size and its impact. That's highly variable in the data that we see. And what about the impact of taking down the antrum? These are two things I hope that will be talked about a great deal in the course today, about the impact of this on some of the metabolism. Because remember, as you make the sleeve smaller, okay, as you change the radius, the flow through that sleeve goes up by a factor of 4, by the 4th power. And the resistance to flow goes up by the fourth power. So you're increasing your pressure dramatically in patients. And that may have a great deal to change satiety mechanisms in patients. It may change gastric emptying. So by way of the last slide, gastric emptying is actually increased for liquids after sleeve gastrectomy. Very interesting. It's not slowed. It's not slowed except for patients that have semi-solid meals. The problem is when we look at these hormonal responses, we almost always uniformly do it after patients ingest a liquid calorie meal. And so we really are looking at just the liquid effects after sleeve gastrectomy, where we say the hormonal response is similar to Roux-en-Y gastric bypass. So in conclusion, short-term outcomes demonstrate comparable weight loss to the gastric bypass. Impact on type 2 diabetes is similar, although a very recent randomized study showed far more robust reduction in hemoglobin A1C from gastric bypass in comparison to sleeve. The changes are robust in response to both fasting and postprandial meal challenges in both the sleeve and the Roux-en-Y gastric bypass. And we need more data regarding specific technique modifications and the neuroendocrine impact of surgery. Thank you very much.